had a wonderful, and continue to have a wonderful career, which has taken me around the world. I have had the pleasure of being invited to over 30 countries, and many of these many times. And what I am seeing is it's not just my own physical therapy community that is inviting me. I'm being invited more and more by other professions, because I think there's a message. It's not Elizabeth Dean's message, as you will see. This is coming from epidemiological information. It's coming from other evidence-based sources. And I want to share with you, we have a very little time this afternoon, but you are critically important in the 21st century. All the indicators are that you will be, or need to be, you're not quite there yet, you need to be dominant this century. As I said in the workshop the other day, we're 12% through this century. So we've got to start moving. And I'm hoping to provide to you this afternoon some of the reasons why we need to do this, but above the reasons, the how-to. I'm a little tired of the talk. We have to move. And we have come from a tradition, a biomedical tradition. And you know what? We have had a rather chronically low self-esteem. We've got to get over this, folks. We have really got to get over this, because our medical and surgical colleagues are not able to do their work and to get their outcomes unless we really start reaching our full potential. And I understand there are many challenges around our doing that. But as I also said in one of the workshops, we have to almost deconstruct to reconstruct. And so I'm going to proceed with this message. And first of all, how many have been to Vancouver? Oh, did you have a good time? Oh, good. Was the weather good? Oh, good. I'm staying. All right. Well, you know, we do have a bit of a rainy season in the winter, but we were kind of nice. It was 24 the day I left. It was rather gorgeous. And some of you might even remember. Do you remember Stanley Park? And well, some of this whole conference area, I guess I can use this, has all now been redeveloped even more gorgeous and lovely, and our seawall is forever expanding. So please come visit. We need your New Zealand dollars. Okay. As you know, one of the things that ignited me, you know, I'm actually having to turn down a few invitations these days because the traveling, which I love, but they're often conflicts. But I said when I had an opportunity to come and to read some of the preliminary work in Achieving a Balance, this provisional document, the AAB initiative that Martin shared with me, I said, I've got to go. Those people are on a track, have the capacity to really to grow, to thrive, and to be on the stage. This isn't, and I like to preface this, it's not a doctor bashing session. I come from a heritage of a medical family, but that was very needful for that domination perhaps in the 20th century, at least up until about 3/4 of the way through. The 21st century is different. It's a different set of challenges. And we have to recognize that and start developing our own leadership skills and capacity to think not only about our own individual professional skills. I'm a physiotherapist and started off in intensive care physiotherapy, moved to the community, and those people in the community are even scarier than those people in ICU because we don't have the monitoring equipment. But we are now seeing these people for many years by direct access, so we have to be prepared to handle very, very complicated problems clinically. But what we're going to touch on are defining some of our common and shared goals, because we all are unique, but there's this common platform that bonds us. And there are parts of this platform that bond us that we actually haven't tapped into completely. Understanding our differences and how we interrelate, building partnerships to maximize our outcomes, and this notion of interprofessionalism that you've heard so much about. But I'm a pretty practical person, even though I'm an academic. I kind of like my grassroots. I like to kind of make things work at the community level. And I think, importantly, what I want to know is when we talk the word change, what's informing that change? You know, it's wonderful to say we've got to reconfigure, we've got to grow, we've got to do things differently than we have. But what's informing? Why do we, you know, why should we? We need some indicators to show what that change should look like. Otherwise, our goals and our shared objectives are going to be for naught because they have no direction, they have no grounding. So let's talk about what that might be. But I'm going to cut to the chase. The planets have truly aligned for you. And it will be your decision, and I have great faith. As I go around the country, or the world, it's going to be one country, I believe, or one group that's really going to have the courage, the guts, the tenacity, the perseverance to really embrace what it means to make those changes. And so I believe this could be good. Not only for the North Island of New Zealand, not only for the North and the South Island of New Zealand, not only for the global region, clearly there's going to be one group that is going to embrace the new challenges of healthcare in the 21st century. And I want to differentiate healthcare and illness care. That there's quite a big distinction. The true healthcare for the 21st century is going to be one group. And I think the rest of the world may well follow. And I'm not saying that loosely. I really believe that this is going to happen. So, but once upon a time, kind of where did we get our origins? You know, I would like to think, I'm married to a historian. And so I'm always, he's always challenging me, Elizabeth, think big, got to think. But I had these slides from before Lawrence came along. But still, you know, what were our beginnings? Well, you know, early on, it was kind of a lot of injury. We died very early. And we also had a lot of acute infection. But fast forward, then came the great wars. Well, they weren't really that great, but the whole illness care system, the healthcare system shifted because, you know, antibiotics were quite prevalent at that point. They weren't as refined as they are now. But then we had to start dealing with more injuries. And I go back to those early journals, and it's filled with a lot of wound healing and traumatic amputations and trench foot, all these horrible things that the soldiers got. The next turning point in healthcare, and particularly in my profession as a physical therapist, were the polio years. Remember those? You may not. Your parents and your grandparents will have all had those vaccinations. But New Zealand was badly hit, as was Canada, particularly central Canada. And the polio years, you go back to the journals, there was airway and lung care, breathing control, coughing maneuvers, suctioning, beginnings of mechanical ventilation, manual muscle testing, gait re-education, wheelchair fitting, orthotics, all these, we responded. We absolutely responded to the need. But I ask, as I look now, how responsive are we being to the needs of our society currently? We've moved from acute infectious disease to chronic lifestyle-related conditions, ischemic heart disease, cancers, smoking-related conditions, hypertension, stroke, diabetes, and obesity. But then medicine became even more high-tech. The pharmaceutical companies got in there, and in fact, there's been a lot of criticism of the pharmaceutical industry for all sorts of reasons. Surgery became both more minimalist, things that used to require, say, for example, opening up a chest wall is now done through keyhole surgery, and then also more drastic surgery as well. So we've gone to both extremes in our advancement. And then we mapped the genome, the human genome. Well, I'm kind of proud because my university was actually involved with mapping the rudiments of the basic human genome. And now there's all this excitement that we're going to kind of tweak this gene and then your diabetes will be fixed. And then we'll tweak that gene and then your cancer will be cured. Well, I'm not a geneticist, but I do know that genes don't work in isolation. You know, it takes tens of thousands, and this kind of research is probably will have most impact to cystic fibrosis, Duchenne's muscular dystrophy, and some of these things that have clear genetic links. These lifestyle-related conditions, we're interested in the phenotype. And you can influence the phenotype. You could influence the expression of these conditions with some very, very simple interventions. So advances in medicine. I think we've all heard about evidence-based medicine. Don't we all embrace, don't we all want to be evidence-based? Don't we all want to practice best practice, right? That's what our ambitions are. We want to be the best. We want to do the best to get the best outcomes. What do we think of advances? Well, when I speak in China, they can hardly wait for this Western professor to come to show all the new bells and whistles and the new machines and the new technology. They just love it. I trashed that. I said, I'm a non-invasive practitioner. The most important thing is the way I think, how I analyze, how I synthesize information, and use non-invasive interventions. For the most part, we do not use drugs as a group. We don't do surgery, generally speaking. Okay? So, but these are now considered the advances. The genes, the mechanical devices, the new design of drugs. But you know what? Biomedicine's not so perfect. Physicians and surgeons are human. There can be negligence, of course, but we do have a certain high proportion of medical mistakes. And now our elderly population, I felt, I lost consciousness when I read the number of prescriptions that Americans, 11.3 prescriptions per person in the US per year. And smugly, I then had to look up a comparable statistic for Canada. You know what? 10.3. This was not good news. This was staggering to me. This was absolutely staggering. On average, that number of prescriptions per year. And of course, with many of our elderly population are on 10, 12, 14, 6. I'm sure you've been there. It's shocking. And now we're seeing children medicated and getting used to taking. There's a whole psychology around taking medication. But then it became all sanitized. Iatrogenic medicine, a whole subspecialty devoted to the side effects of biomedicine, drugs, and/or surgery. But now a new word, because when you take a drug for a bad effect of some surgical intervention or medical intervention, then that has a bad effect. So then you have to take another drug to counter the side effect of the first drug. So that's called cascade iatrogenesis. So, where are we going? How is the health piece being lost here? And of course, I'm not going to spend a lot of time on some of the issues around pharmaceuticals. Of course, we need the drugs. We need to make good use of this wonderful resource that we have. But it's become big business. And you know what? We cannot sit back and be complacent about this. Because basically, as the non-invasive side of healthcare, it makes our job very difficult to do when pharmaceutical companies are wooing or giving out free samples or giving physicians free cruises. When I speak at a medical conference, I've had champagne waiting for me in my room with chocolate-covered strawberries. But I mean, I have to do it, right? When I go to physical therapy conferences, you go into the exhibit hall, it's basically cement. I go to these conferences, it's 3-inch shag carpeting with free cappuccinos, I mean, it's just they're in a different stratosphere with the resources available through the drug companies. And I'm going to come back to this point. And of course, in medicine, with the biomedical domination, when you have a hammer, everything is a nail. So, yes, a patient goes in, they see their physician, and the first thought is, well, what can they prescribe? Because that's what they're trained to do, is to prescribe. We need a new model. So, certainly, biomedicine does acute care well. They do acute trauma really well. They do ICU well. But this chronic, lifestyle-related condition that so much is impacting the lives of people in our societies and in our communities, their outcomes are really quite poor. And how can we help to address that? Well, the evidence-based practice piece is a good one, and I think we're all now in love with the randomized controlled clinical trial. Well, let me tell you, that trial, that's going to be, everything is hinging on, well, do we have a randomized controlled clinical trial? But I want to share with you a very important study for us. It's parachute use to prevent death and major trauma related to gravitational challenge, a systematic review of randomized controlled clinical trials. I think you get the point. This is not in any shabby journal. British Medical Journal. Okay? Let's read a little further. Okay. The objective, to determine whether parachutes are effective in preventing major trauma related to gravitational challenge. And they use all the right buzzwords and the mesh terms and so on and so forth. Well, let's kind of just get to the bottom line. What is already known about this topic? Parachutes are widely used to prevent death and major injury after gravitational challenge. Parachute use is associated with adverse effects due to failure of the intervention and iatrogenic injury. Studies of free fall do not show 100% mortality. And what does this study at? You always ask, well, what's the implication? No randomized controlled trials of parachute use have been undertaken. The basis for parachute use is purely observational, and is apparently its apparent efficacy could be explained by the healthy cohort effect. And individuals who insist that all interventions need to be validated by a randomized controlled trial need to come down to earth and come on. Okay, well, so what does that? So I had to preface that because I don't have the randomized controlled clinical trials to support my health factoids. But here we go. Healthy people get sick less often. How's that for one? When they do, they are sick for less time, recovering faster with fewer complications. Healthy people need fewer biomedical procedures, take fewer drugs, and need less surgery. When they need these, they need less medication for less time and benefit from less invasive surgery. Healthy people are less social and economic, I hate to use the word burdens, but that's a World Health Organization term, to society. Healthy people stay in the workforce with less absenteeism, long-term sick leave. Healthy people tend to leave their jobs for reasons other than sickness. Let's get serious about health. Let's not be fearful because we don't have a randomized controlled trial to show that healthy people get sick less often. Can we start with that assumption? Is that okay with you? We're pretty practical people. Another point I want to mention, the way we're going in illness care, well, I really question the ethics of it, but above that, it's not sustainable. I want to do a little comparison for you. The costs, now the gross domestic product, as you know, is a sort of a general index of the wealth of the country. So the proportion of our GDP, of which health cost is reflected, the doctors per 1,000 population, and hospital beds per 100,000 people. Okay, for the US, 16.2. The United States has the highest cost of healthcare in the world, and doubling really any other comparable country. It has some of the best illness care in the world, but also has some of the poorest. For an industrialized country, it has some very, very poor care to some segments of its population. 2.8 doctors per 1,000 population, and 3.1 hospital beds. Canada, well, we're about 10.9% of our budget goes to healthcare, 1.9 doctors per 1,000 population, and 3.4 hospital beds. Now let me share with you how New Zealand stacks up comparably. 9.7 of your budget, so you're kind of not dissimilar to Canada, 2.3 doctors per 1,000 population. But I'm a little taken aback, given that I spent my week and continue this week in some of your home health centers. So I'm a little staggered to see that compared with some comparable countries, the number of hospital beds are double. This is something for us to investigate in this country. Now, when you collect, this comes from a very reputable source, but we need to, we're taking people out of hospital. We want to do the hospital at home kind of model. People do better at home, it's less costly, and so on. So this, I think, is something that is a statistic that is worth following up in this country. So let's talk about 21st century practice versus 20th century practice. Some of you will have seen and are familiar with the International Classification of Function, named Disability and Health. I raise it for a couple of reasons. One is we're getting away from just looking at body function and structure, which was formerly termed impairment. That was the whole premise of the biomedical model, and is still alive and well. But we know that people can have significant challenges at this level, and yet that's what we do. We try and promote and ensure that they have maximal activity and that they're at their roles in life, their participation are maximal. So we, in the allied health profession, spend a lot of time kind of working toward, yes, we attend here, but ensuring that people can do what they need to do in the day, because that is what gives life meaning. But that whole model is based on the premise and definition of health. But went before the World Health Organization in 1946 and was legislated in 1948 and was adopted by the World Medical Association and later by the World Occupational Therapy, World Confederation for Occupational Therapy, and the other for physical therapy. And I think we know this definition, but I question how well have we integrated it? How does a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity? Health is a resource for everyday life, not simply the objective of living. It's a positive concept emphasizing social and physical resources, as well as physical and mental capacity. This has underpinned, a large number of our professions. And yet, are we really putting this into practice? We've got the words. But I like to think of evidence-based, yes, I'm all for evidence-based practice, but how well informed is the practice that we actually do in terms of our priorities? What should be governing where we put our priorities? If we go mortality by country, we see that across even the low-income countries as well as middle and high-income countries now the lifestyle-related conditions are creeping up. Let's see for New Zealand. Virtually, your top 10 are lifestyle-related. I'm not saying caused by, but have a significant lifestyle-related component. Lower respiratory tract infection, I didn't highlight in red, but if you have one of the other conditions, the chances of your having a lower respiratory tract infection that could actually lead to the end of your life is fairly significant. I want to just talk about a few things that come from health documents. And I know there's some similar health documents here in New Zealand. And I use these, mine at home, and I'm going to show you, because I want to show you some of the things that we've done in physical therapy in terms of trying to embrace health practice, and that you might be able to consider in your own unique professional situations as well as a group here. The major concern is our collective ability to provide enough trained and experienced public health professionals to undertake the tasks that are flowing from a wide suite of public health priorities. Now, who are these public health professionals? To me, that's a part of what each of us should be doing. We don't need somebody other. They may, perhaps in terms of policy, might be a good idea, but we need somebody who embraces this every day in their practices. Of the two major reports, the Romano report and the Kirby report, I'm going to highlight just a few things. I went into more detail in the workshops. The gap between knowledge and practice is still too great. This was based on focus groups that went right across Canada. A national strategy must be developed to achieve both an adequate supply and optimal use of healthcare providers, such as ourselves. We need a commitment of a system that is responsive. Remember I talked about the war years, the polio years? Now I go to my journals, and they're not filled with information and initiatives and intervention, evaluation for lifestyle-related conditions, prevention, reversal, as well as management. It's heavily musculoskeletally dominated. Well, why is that? I think we got stuck in the polio years. As we got more sophisticated, we got accredited programs, and we, you know, in our sophistication, we've almost hamstrung ourselves. But we have ceased to be as responsive as we need to be. Obstacles, the central and predominant focus on hospital and medical care, the most expensive parts of our healthcare systems, physicians, doctors, and drugs. As I mentioned in the workshop also, if anybody tells you that you're expensive, you are a drop in the bucket. Absolutely a drop in the bucket. But we obviously need to put our resources, our time and energy into the things that matter most in our shared communities. Now, I promised that, you know, I'm not going to talk about a lot about studies. And one thing I tell my students that I will literally go into a catatonic state if I see one more study on the benefit of exercise. You know, it affects positively your mental health, every organ system in your body. It prolongs your life. It's the wonder drug. It's absolutely the wonder drug. Do we need another study? But one caught my attention. And I had to share this with it in the workshops. Healthy living is the best revenge. You know, so the title was compelling. I looked further. Oh, yeah, a sample size of over 23,000, not too shabby. Let's read further. Very elegant study rated these 23,000 people, smoker or non-smoker, body mass index of over 30 or not physically active, and that's not a high amount of activity. That's just sort of walking about for 3.5 hours, less or more. And they had a way of gauging healthy eating. And wow, no drug could ever produce this. A drug is considered marketable if it has a 5 or 10% benefit, and they have this number of patients that sort of justify treating it. So if they kind of avoid one death in 1,000, that's considered marketable. 93% after 8 years, 7.8 to be precise, 93% reduction in type 2 diabetes, 81% risk of heart disease, 50% risk reduction of stroke, and 36 decreased risk of cancer. And I think that may be lower because 8 years isn't very long in terms of cancer progression. Wow. With a little bit of information from you folks, irrespective of your role, and if we work together on this, so our patients and clients are hearing the same message from all of us. And this is, we need to let the New Zealand Ministry of Health know, the Canadian Ministry of Health know, that this is not acceptable to the allied health professional community of this country. This is not acceptable. And we really have to take this very seriously. Our outcomes, fewer patients. When I show that slide in the United States, because everything's based on more patients, they can't quite get their head around. Fewer patients, think, oh, I won't be able to feed my family. Believe me, when your 115-year-old patient comes in with a sprained ankle from a skiing injury, there's going to be more than enough work. Decreased doctor visits, decreased number of medications, if at all, decreased dosages, decreased hospital visits, decreased length of the hospital stay. These are our outcomes. I want to tell you a little bit about statins. This, not so long ago, I forget which country I was in, maybe the UK, in the paper, the anti-cholesterol drug statin, as we know, is being marketed a lot, cuts the risk of stroke or heart attack by 20%. Now, they are really happy about that because most drug effects are kind of in the 5 to 10% range. So and this came out of Oxford. And they were so happy that they felt this should now be used preventatively because this is such a good outcome. And I'm thinking, we've got that great result, just with a few little basic lifestyle changes. What are we talking about? This pales in comparison with healthy living, which is protective of a range of conditions. Statins might help address your lipids, but is it really changing? Like if you're going to change and have a more healthful diet, then you're going to be limiting your risk of all sorts of other conditions. And promises greater well-being and reduce side effects or potential side effects of the drug. So, we have to really see where does this fit. And I'm going to show you a few things that we have done. We've been very proud to get our textbook out, the 5th edition. And we had a chapter there that we included in the 4th edition. And the first, this was a new one, Epidemiology as a Basis for Informing Contemporary Physical Therapy Practice. The working title of that chapter was originally for cardiovascular and pulmonary physical therapy. We thought, no, this is across the board of areas of clinical practice and care. So if you're treating a bad back and you have somebody who has, the risk factors actually for back pain are the same as heart disease. And now I'm beginning to think this is epidemiology needs to underline, particularly for chronic management, care management, and management of the needs of society. This needs to underlie healthcare in general. And another special issue, we looked at these, this was physical therapy practice in the 21st century, a new practice paradigm. We decided we're going to take the bull by the horns and say, what should we be doing? We need to be doing, smoking cessation. But how can we do that within the constraints of a resource-constrained and limited time or busy practice? Well, the literature says there's some very effective ways of doing that. Brief advice, motivational interviewing, same with basic nutrition, same with basic recommendations for a little exercise. We sleep poorly. Westerners tend to sleep very poorly. And if you're not sleeping well, it impacts your health. Your risk of heart disease goes up, your risk of hypertension goes up. It's not causative. We don't quite know what the mechanism is. And of course, if you're not sleeping well at night, you're not going to function well in the day. Stress. It used to be the big kind of lifestyle crises. Now we know that daily hassles and that cumulative stress, that cumulative fight or flight changes that happen when we are under stress and pressure. So in my own clinical practice, now all our patients complete health profiles, very simple to do, health behavior inventories, risk factors, and in the impairment days, we continue, of course, to look at the manifestations. And this could be in somebody who comes in with back pain. I see a group of people who had polio years ago and now are having, this coupled with all their former problems with lifestyle-related conditions. A few patients. And a 44-year-old man, low back pain. If he's a smoker, how does that impact his assessment? How does it impact his intervention? How does it impact his follow-up? This might, we used to kind of just write that down and move on. Now we have to kind of pay attention to smoking is actually going to impair his healing and repair of his back. It's going to reduce his circulation. It's going to impair his immunity to some degree. And we have to deal with, certainly, his more serious problem. A woman with osteoarthritis and hip replacement, type 2 diabetes. How does that affect the assessment, the intervention, and the follow-up? So these secondary problems are actually the more important, the more serious problem. And certainly we want both of these individuals to be comfortable, but we have to deal with the more serious problem. Little Joseph with anterior cruciate ligament strain has abnormal blood profile. I'm not going to be talking a lot about children, but our children are not expected to live as long as you are, the parents. This is the first generation ever in the world recorded history that this generation of children has a shorter or similar life expectancy. Each generation usually has surpassed their parents. And it's our lifestyles that are being responsible. So how can the challenge of knowledge translation? Well, the American Physical Therapy Association has given us some guidelines. And so to make that easy, we also have more alerts about monitoring blood pressure in every patient. And also, there is controversy about assault, but the majority of articles that high blood pressure is linked to salt consumption. It's the second leading cause of death in the US, and the National Academy of Science in that country has said that 25% reduction in hypertension if people cut salt and ate more vegetables, fruit, and lean protein. And let me translate that for you on their projections that reduce salt from 3,400 milligrams to 2,300. That's still too high, but it's a third reduction. Could cut cases by 11 million and lower healthcare costs by 17.8 billion. I mean, I can't even imagine $17.8 billion when you reduce your salt by 1/4 teaspoon per day. This is staggering. This is a very simple intervention, a little conversation. Sure, it doesn't guarantee change, but patients hear things enough. And if we can't be the role models and the health coaches for the patients, who will be? At the DASH diet, you pass this by at the supermarket, the dietary approaches to stop hypertension. Oh, in 14 days, spare me. This has been documented. Some patients revert their blood sugars within 2 days. Certainly, it won't work for everybody, but at least if their medication can be reduced, that is dramatic and very important. Reversing heart disease, you could do that. You can reverse heart disease, you can reverse hypertension, you can reverse type 2 diabetes. Perhaps not for everybody, but statin doesn't work for everybody. Very dramatic, and look how long ago. I want to purposely selected this one from 1996, Dean Ornish's work. These results were published years ago in the Journal of the American Medical Association. And look at this change. Yes, it took 2.5 years, a little more perhaps, but look, a very plugged left anterior descending artery and fully patent. And atherosclerosis is throughout your body. We see it manifested in the heart, but it's throughout your body. So if we have reduced through simple dietary change and opened up the patency of this particular artery that could have killed this individual, that will be opening kidneys, better circulation to the brain, to all the organs. So how simple is that? The disease of diabetes type 2 is preventable. These are the words of the World Health Organization, and in the majority of cases, reversible. Reversible. And this was their document that came out in the late 1980s, and there have been many, many articles as well as books written on reversing diabetes. And that so-called diet or the dietary recommendations, I don't actually like the word a heart diet, arthritis diet, and stroke diet and high blood pressure diet. It's just good nutrition. It's just good basic nutrition. Waist growth recommendations are better diagnostically and predictively than many of the lab tests. Waist girth, body mass index has been one that has been surpassed by waist girth, and waist to hip ratio is a very, very good indicator of health risk. Now, I love this particular slide. This is a very energetic physical therapy student at a university that will remain nameless in Canada. And of course, we're all into branding and profiling our strengths within our departments. And this is a student, and makes for a really good optic, yes? Really nice visual. Student seriously contemplates the accuracy of her goniometric measurements. And I could really identify, because I remember as a student trying to get that last half inch. But, you know, is she missing the bigger This wouldn't have been quite such a good visual. You know, her sitting in a plinth with a food chart. You know, yes, we're trained as nutritionists. We're not pretending to be, but, you know, we know enough about basic nutrition to get the conversation started, to do some preliminary assessment, to initiate and or support refer. We've got to kind of refer to each other more to do those kinds of referrals. And, you know, people love the dieting industry is a multi-billion-dollar industry in North America. But it's been shown repeatedly dieting makes you fat. So, I mean, it's perfect, isn't it? If you want to make a lot of money, keep offering these promissory weight loss programs. But healthy nutrition is the best for weight loss. Sedentary activity. You know, we have these guidelines. Have to work 78 to 85% of your age predicted maximum for 20 to 40 minutes, 3 to 5 times a week, and you'll be nice and fit. And you know what? What are you doing the other 23 hours? The Australian literature has been very strong in the last 10 years. You could be doing all that wonderful exercise, and you know what? If you're sitting like most of us are, unfortunately, that is an independent risk factor for cardiometabolic disease, meaning both heart disease and diabetes. So we've got to, it's a regular activity every day. Now, so what is the right amount of exercise? Now, I'm not suggesting you run home and do this, but, you know, we now know that, you know, I used to think unless I could have time to run for an hour, it wasn't worth doing, you know, and I think we've all been, I only have half an hour, or 50 minutes, I can't do it. But the notion of micro-exercise now, that it doesn't really take much, that it's cumulative, you know, moderate amounts of twisting and bending and lifting actually do our health protective. And we've actually kind of marginalized this, it's not, you know, this lower level, moderate level of activity in sort of 10-minute bouts. This can be really, really beneficial from a health perspective. But I did read in the newspaper about a year ago about how, you know, people can kind of shake their legs, they're a little bit hyper, and that this could actually be a good form of exercise as they sit there shaking their legs because they're consuming calories. I couldn't quite go that far in making that recommendation to my patients. But some of you I know in the workshops who talked about pedometers, beautiful, check, have a little check, you know, and see if you're racking up 10,000 steps a day. It's a pretty good guide to see if the level of activity. I absolutely accord sometimes when I only do 1,500. Okay, so, but we do have to kind of think carefully about our exercise. And using, you know, I took a trip yesterday afternoon and went downtown. There was some beautiful stairs. I actually am recovering from a little bit of a metatarsal fracture. So I too took the escalator. But all of the high school students were over on the escalator, and there was this beautiful set of stairs at the station. It was such a shame. So we have to think about, you know, in the impairment model, you know, Mr. Jones comes to us at a certain point in time, but now we have to think, what has been the cumulative effect of his lifestyle? And what do we want for him for the next 60 years, the 100-year health plan? And with this simple health recommendation that are done in a systematic way, we can displace his threshold for chronic conditions, and we can lower the rate of the progression. Because we all want to live a life that's free of illness, free of disability, and at the end of our life to have as little end-of-life morbidity, mortality, disability as possible. Right now, we're very good. People are having their heart attacks and their strokes in their 30s to their 50s and can look forward to, you know, 4 or 5 more decades of disability and really tremendous psychological hardship in terms of their health. So I'm going to just talk about the 5 A's before we wind up. This is again, ask, advise, the World Health Organization. A very simple system: ask, advise, assess, the willingness to discuss the health behavior under discussion. If willing to discuss, then you can assist and arrange for follow-up or to go to the appropriate health provider. If unwilling to discuss, you've got something to fall back on. The 5 R's. The 5 R's. To discuss the relevance and potential for change, the risks that the person might be exposed to, the rewards of changing, the potential roadblocks that they envisage around changing, and repetition of the message. Motivational interviewing. This is an evidence-based interviewing strategy that is a way of counseling. Again, it's not finger-pointing, it's very supportive, but it's mobilizing the client's own intrinsic values and goals to choose to change. It doesn't take much time. The stages of change helps the patient figure out, am I really ready to change, and how much time and effort should you be putting into this at this time? If they're contemplating, you can kind of go a little bit more forcefully, preparing, action, and then there's also maintenance. So I'm just actually going to zoom to this one. There was a very famous French philosopher, André Gorz, and he wrote these words about 30 years ago. Western medicine prizes rare diseases and costly technology to which only a minority can have access, and it neglects the simple and inexpensive non-invasive techniques. Techniques that would be effective against everyday conditions that constitute 95% of illnesses or morbidities. And he also went on to sort of think about how enamored we were at that time with the Concorde. Remember that big plane that could get, you know, from you know, on the Paris to New York in 25 minutes or something remarkable, and not like that, but, and yet public transportation nobody gets excited about, and that's the people mover that we really need to think about. And you have a challenge. The challenge being banding and working together to promote healthy lifestyle choices by being good role models ourselves, sustaining healthy lifestyle choices. Now, these might seem like formidable things, but how do we do it? Well, you know when we decided to go to the moon? You know what? We're pretty smart. We actually did that. We did it, so we can check that one off. When we decided to map the human genome, well, you know, it still needs some refinements, but we did it. But promoting healthy lifestyles, why is there this block? Got all the information. Sure, they're going to continue to know and figure out what works, what doesn't, but we've got so much there in terms of evidence base, and we just have to translate it. We have to now embrace this and put it into action. We can do it, and I hope that maybe this group is going to lead, and we can check this off as part of just something that we do. I want to just, but selling health, I think about how do we do this. So I went to the marketing literature. I said, heck and know how we can do this, because we always know those people who you give them lots of information and nothing changes. Well, I went to why we buy, the science of shopping. They'll have the answers. The dynamics of persuasion. I have to tell you, if I use the same principles of behavior change that these marketers use, I would get nowhere with my ethics committee at the University of British Columbia. I want to actually do that and then publish my rejection because it hamstrings us why do we have this difference in what's ethical out there in the marketplace? You know, it's really a bit disturbing. That's a very frightening read. But, you know, it wasn't so long ago when these are the kind of messages that were used. And now all the Marlboro men have died off due to emphysema, but you can see that when I go to China now, you can see this because the West is best in the eyes of the Chinese, and when you see now the Marlboro man having a Chinese face, this is also disturbing. They're going to markets in the low-income or lower-income countries. And of course, bowing to public demand, I thought this was a bit of a laugh. This appeared on the other stuff. And McDonald's, well, they'll know. They do. You know, there's nothing about McDonald's that is not really engineered. The color, the temperature, the shape of the table, the type of the table, where the signs are, everything about McDonald's. The salt, the sugar, the other addictive qualities and substances in their products. And of course, it has been, you know, I see now McDonald's everywhere, Kentucky Fried Chicken, in the middle of the desert in Saudi Arabia. And Coca-Cola, their marketing strategy, mission statement, a Coke in the hand of every man, woman, and child on the planet, and I understand that's actually true, compared with potable water bottle that's drinkable. So we're thinking about social determinants of health, we've got to get serious about that. And look at the amount of sugar in these products. You know, if sugar and salt, as well as tobacco, if they went before the food board today for approval, they wouldn't get approved. These products would not get approved. And of course, the dieting makes you fat. That's the success of the multi-billion-dollar industry. So you as an allied health group, you have enormous potential. More power than you would imagine. Coming back to our low self-esteem, when you look in the mirror, you've got to see something different. You have absolutely got to see something different. And our play is small in the world. And I would hope that we actually get Hippocrates honorary membership in this association. First, do no harm. The function of protecting and developing health must rank even above that of restoring it when it is impaired. And this was stated 2,000 years ago. It's something that we as health professionals, you know, need to embrace. And apparently, you know, we're supposed to be part of the medical school graduation ceremony. I'm not sure that really sunk in about what that really means. So how to change the world? I love the words of Margaret Mead. I actually saw them in the hallway here. A small group of thoughtful people could change the world. indeed is the only thing that ever has. So I used to say, I use the ripple effect and that kind of, but now in my talk I'm saying, no, this is a tsunami. You could really change it, but doing it collectively, we are going to make a far bigger splash, a far greater impact than we can individually. And there's some group in the health professions that needs to take the lead and to take this seriously. So I challenge you, and I hope next time I see you that you have made some differences in your practices. Thank you very much.
We've got about 5 more minutes, don't we? 5 more minutes, that's all everybody needs. But hopefully that gives us a taste, because that, I don't know, it's probably about the third or fourth time that I've heard that. But I think the challenge for us collectively to take from that is, where does the answer lie? If we look at our population, if you look at Counties Manukau, if you look at the rate of diabetes, if you look at the rate of cardiovascular disease, and if you look at the group that spends time with patients, who sees them for the longest, who has the longest interaction, no disrespect that other professions will have interactions, but I think that how much time does a social worker spend with the patient? How much time does an occupational therapist spend with the patient? How much time does a play therapist spend with the patient or with their family? And if you start to think about needing to influence lifestyle, you're the answer. We are the answer, especially when you look at our population. So I think that's the challenge that we need to take away from this. And Elizabeth, if I can thank you for that. I think it's a very, very relevant challenge that we have for our population, but we're going to leave that up. So I think it's, we can do this. So thank you.
Yes, you're very welcome.